Hello. I just want to ask Dr. Valenti. I've been very impressed from your presentation. Just question. We are doing bone block procedure, and we are studying on doing it, and we are using double button fixation.
In microphone.
Sorry. We are doing many cases, not many, quite good enough, with bone block procedure combined with soft tissue augmentation with ISA. Okay, but the question is for the bone fixation. Do you think that because Pascal is using only one button, and he says that he has good results, no macro movement. So my question is, as using one button is better than using two because the learning curve is low, the stitches sometimes doesn't bend to each other, so it would be much better to use only one button. Do you think that the healing process of the bone is due on the double fixation beside one fixation? Or you think that using only one button you could have the same result in bone healing like Pascal Bolo says? Do you understand the question?
Yes, very clear.
Do you like the question?
Yes, I like the question. I think that there is two indications. If you have a lack of bone and you use a small button, I think that is not enough for me because you don't restore the anatomy of the glenoid. The second point, if you use a small bone, you have a small surface. Of course, you have a better chance to obtain a healing because when you use a big bone graft, many times the superior part of the bone graft, there is osteolysis. We saw that with the screw. We saw that with classical Latarjet. When you use a big coracoid process, you have systematically osteolysis of the superior part of the coracoid bone. Not depends of the screw of the button. This is not the problem of that. If you have a big bone graft, you have a less chance to obtain 100% of healing. It's the reason why Pascal decided to use a small bone graft. If you use a big bone graft with one on the button, you have a rotation problem and you have not a good fixation.
But he says that he doesn't agree with the macro.
Okay, thank you. Excuse me, would you like to come all the speakers to sit down here so that we can hear you better? All the speakers here, please. Here. You can sit here.
Not me. I'm not a speaker.
Manu,
I would like
a
to...
question from this side now.
Sorry.
Yeah, in microphone. Oh, here.
Felipe, the others, if you like to answer me. You have a patient with a Bony procedure. This patient has done a Latarjet. He's 30 years old. There is some kind of osteolysis, partial osteolysis, absorption. This patient has no subluxation or redislocation, but he has a very positive anterior apprehension sign. So he feels discomfort after this operation. How do you approach this patient?
Can I add something to this question? I would like to ask something from the radiological point of view. I'm alone here, but
it will be the next question.
yes, but it affects this question.
Oh, okay.
Sometimes when we have partial or total absorption of the bone graft, the question is to all of you. I count a tissue that has the density of soft tissue or denser than soft tissue. What is this tissue? It is a granulomatous tissue. It is connective tissue. And what is the result? What's the results for the movement, the motion, and the ROM of the joint? Does it help? Does it prevent the dislocation? Which is the complication of this tissue formation there that I don't know how to characterize it, but with the Hounsfield units that we can measure, it's something higher than soft tissues. Okay.
Okay, I'll start with the first question. So you have, I would say, a failed Latarjet. So I think we can consider that a failed Latarjet. Well, first of all, the workup. You gotta get the proper imaging, either an MRI or CT scan. CT scan probably in that case is the best choice to enable you to check exactly how the bone stock is. And then if you have minor bony loss, then you may be facing a case in which the soft tissues were not properly addressed. There are reports and there are evidences that revisions of failed Latarjets done arthroscopically can do well, which allows you to infer that probably the soft tissues were not addressed properly in the first place, in the first surgery. So that leads you to believe that there's still room probably to do some soft tissues procedure in that patient. In case there's some important bone loss, then they hadn't even had some bone block. Considering your question, I really don't have an answer for that because I never did any, histological studies on that. So I would pass to the next one.
Yes, it's very speculative. The first thing you have to figure out is why did the Latarjet fail? And is it because you have had a bony resorption and there is no longer any bone there? Is it because you loss of fixation? Or is it because you had a totally insufficient operation in the first time? We all know that pure inferior instability is really hard to treat with a Latarjet procedure. They're really hard to treat with any procedure. But that is one of the reasons why a Latarjet can fail. So I think the first thing you have to work out is to find out what was the problem in the beginning and why did it fail.
I agree with you. Maybe the initial problem was hyperlaxity. So maybe at the beginning, these patients should do some extra exercise for reinforcement of the other shoulder muscles. And regarding your question, we can just say when we do the revision several times, we found like a scar tissue, and all is stick together. So conjoint tendon is completely stick into the capsule. So when we do the revision, we use our biceps or everything else. So we just reinforce this remaining scar tissue back to the glenoid if there is no major bone defect.
My question to all the panelists.
Should we answer the other one first? Yes. So of course you have to examine the patient and try to find the reason why it's still unstable. And then you have to consider your bone block. Is it too medial? Is it too high, too low? And of course, if the patient has a Hill-Sachs defect, you can sometimes add a remplissage if you didn't do that for the first. And according to bone resorption, we have operated like 110 patients now. And for 2 or 3 of them, we take them back for 1 year follow-up with CT scan. 2 or 3 of them, the bone block is totally resorbed, but they are still stable. So there are some scar tissue in addition to the sling effect that still works.
The first question to Manos, if you have a good bone nailing in good position and you have an apprehension test positive, sometimes I think that for me is a failure of soft tissue repair. Because if you do only Latarjet, you don't stabilize the humeral head. There is always an anterior translation. And in abduction and external rotation, you have an apprehension test for the athlete. It's the reason why I think that if you do Latarjet, you have to do a Bankart procedure to augment the stabilization of the shoulder. This is my feeling in my patient. The second point, many times there is a scar tissue between the bone and the anterior glenoid rim and coracoid process. I think that the stabilization is not enough. Because if you have a not perfect matching of the two surfaces, if you use on the button, for example, is not enough. There is a little mobilization of the bone and there is a resorption of the scar tissue. But I have some patients, if you do soft tissue repair, combined with this technique, there is no failure. But I'm not satisfied regarding that. I think that the cause is not perfect matching and not perfect stabilization with on the button. Because at the beginning, I thought that on the button was better for adaptation. That screw is not true. The screw can compensate a partial matching better than on the button, I think, in my experience. It's the reason why I had more scar tissue with on the button if it's not perfect.
My question to all the panelists.
Can I?
Just a comment. Doing the bone block, doing the bone block procedure, we repair the capsule all the time, and we take a CT scan at 4 months and at 1 year in order to see two things: first, the healing, and second, the absorption. And it's interesting that the grafts are healed, and after a year, some of it, or part of it, is absorbed. We have never seen total absorption to the initial rim. We have seen that it absorbed some and reproduced the glenoid surface, the inferior part of the glenoid, if there is a bone loss. So, and all these patients were stable. Happily, we didn't have yet dislocation in these patients. And so probably it's something there that replaces the bone. And this is very strong, and so that to stabilize the joint. And not doing letter Z, repairing the soft tissue was more important for us. And we tried to do our best and tight the capsule as much as possible. And this probably has to do with the
My question.
Can I?
Continue the question. The question. My question is: so you agree with Pascal Boileau that he says that for him is enough to do the fixation with one button? You cannot hear?
I think we had to remember when Pascal Boileau has such good results, the patient population is totally different than ours. Because in France, the first operation you get, it's 70% get a Latarjet for the first time. And of course, he repaired the capsule and he had good results. But for the rest of the world, 90% of the patients has a Bankart. So it's kind of apples and pears.
Yes, but
Yes.
so you can.
My question to all the panelists: in how many percentage of your patients you will see some bony fragment, bony Bankart? Because as we know that the indications for this Latarjet is growing more and more. But if you see the paper of Dr. Hiro Sugaya, which was published in 2014, he has found almost in 60% of patients a very large bony fragment. And he has already published 3 years functional follow-up and the healing of that bony fragment. So what I feel, out of 10 patients, at least in 2 or 3 patients will have sufficient bony piece to repair along with the labrum. Because problem is that open Latarjet or ortho-Latarjet is not free, is not without the complications. So what I feel, it is always better to do MRI, if necessary CT scan, to identify these bony fragments and try to do the bony Bankart repair. So what are your thoughts on this?
Bony Bankart repair is very nice if the quality of the bone is good, if there is no resorption, no osteolysis. But we know that after 3 or 6 months, there is a resorption of the bone with a medialization of the bone. We do Bony Bankart repair as Sugaya technique after the trauma, after 1 month or 2 months. But when you see the patient after 6 months, I think that this bone is not useful. This is completely resolved. And it's not possible to use this technique.
Enrico?
Yeah. So
just comment on that also, because very short, because we have almost totally stopped doing bony Bankart fixations. Why? because most of the patients with the bony Bankart are in the elderly population. They're 40 years or more. And we find that if they are stable after reduction, there is no need, they don't become unstable. And that goes for even fragments up to 20-25%. They remain stable. They have, as Philippe says, they have a partial resorption and medialization of the fragment, but they remain stable.
Enrico? Yeah, I mean that some of the failures are for lax patients and so on are due to the axillary pouch that is not retensioned, and the most of procedure act on the anterior inferior, but not just at the inferior part of the capsule. So it is like if you hold the trousers just from one part. And I mean that any surgeon should keep in mind that the trousers should be held by the two sides, so back and forth. And this probably is one of the cause of recurrences in Bankart repairs, and one problem of some instability that is not a dislocation, but is a symptomatic instability of an in lateral procedure. What do you mean about?
So you're talking about the reinforcement of inferior glenohumeral ligament that we usually don't stretch enough when do Latarjet. This is what you mean?
Yes. That is, I suggest, I teach going to put a posterior, to detach all the capsule down and to put the first anchor from posterior, and to take the bites of the tissue from posterior first to reduce the axillary pouch redundancy.
In arthroscopic repair it's possible, but in Latarjet, so you know you have to take away. So in open this is very difficult because you remove part of the capsule. Yeah. So in arthroscopic they have to answer.
I Latarjet with Didier Pat a long time ago is 90, and we did a suture of the capsule to the AC ligament, and we didn't do any Bankart. And my rate of apprehension test is like symptomatic instability after Latarjet was 25% or 30%. And after I decided to do a Bankart repair, like you describe, and I do a posterior inferior knot now at 7 o'clock, and I do 3 knots anteriorly, and I do a bone graft like Latarjet, and I think that the rate of apprehension decreases. And I am completely agree. And when I see some Latarjet, they destroy completely the capsule, I am a little afraid about that, because if you do a precise examination of athlete with abduction, external rotation, for example, handball or rugby player, they have apprehension many times. And I think that is important what you talk.
Thank you. 2 last questions, one with offer and the second one with Russian.
Excellent presentations. I want to be a bit provocative, as always. First, apologize to all my French friends. I think that in the last recent years, we've been pushed all over the world to do more and more Latarjet procedures. And I think it's a bit out of context. I've had really good friends, and they push really hard. But if you look at E.J. Ito's series, when he described the on-track, off-track, when he looked at his own series, in 93% of them, he could put them on track by doing soft tissue procedure, just Bankart repair and capsular shift or whatever. Another 4%, he could get them on track by doing this and a remplissage. And only in 3% of them, he had to do a Bony procedure. Now, we know, and we all discussed, there are really major complications with the Latarjet. And my question to everyone is just a word of warning. You know, we all talk about this, that there are more redislocations with Bankart repair. Can I ask you, in a 22-year-old boy, what is a worse complication? That he dislocates again, or he's got severe osteoarthritis with the 2 screws actually destroying the head? Just to think about that. So I think we need to bear in mind that we need to, the pendulum need to move a little bit back towards soft tissue operations. And I think that these techniques that Philippe presented and Ettore described and all that are by far more safe than to do a Latarjet. Just my opinion.
Was that a question or?
No, there was a comment.
So I have a question for.
The question was what's worse, to have another dislocation?
So I have a question for all the panelists.
My answer to offer is if you do a Bankart, you have to do well. If you do Latarjet, you have to do well.
Yeah.
And if you do a screw inside the joint, it's not acceptable. You don't criticize this technique because you put the screw inside the joint. I criticize the surgeon, but not the technique.
But we see more and more of these patients coming to us with the screws inside the joint.
I think that is clear. Whatever the techniques, there is a learning curve, and you have to respect the patient. And I agree with her that you have to go to the laboratory many times before, correct, because never the one time on the patient. And if you respect these rules, I think that we have less complication in Latarjet or less complication in Bankart.
I have a question for Philippe and other people. My disclosures, I love French people, so don't worry, I won't trouble you. So
don't go too long. I love French people as well.
My origin is Italian.
So
don't worry.
I have a question related to your fixation modality, because somebody spoke about the adjustable loop devices which you use. We have been using these adjustable loop devices in knee surgeries, and there has been an effect known as bungee effect. You know, they eventually give up, and there is 2 to 3 millimeter. Whether you use Arthrex, Smith & Nephew, Stryker, Mytech, all these companies, they have got 2 to 3 millimeter of bungee effect, which is inbuilt effect because of that adjustable loop, and that is why they have a commonest failure rate in ACL reconstruction. So similar failure rate will be seen in your Latarjet type of procedure when you use these adjustable loop devices. Because I think the compression screw which we use for Latarjet is giving us more force, and bone healing with compression is always better than healing with the just pulling.
We use a tensioner, and we put 100 Newton first, and you see very well the compression, and after you put more 100 Newton. And I think that because at the beginning we had no tensioner.
So I'm not talking about day one, I'm talking not later, because the day one, that is on the operation table, you'll feel it's very tight. But the bungee effect starts once patients start mobilizing it. Similar effect was seen in ACL reconstruction.
Yes, maybe I agree with you. Yes, there is 1 millimeter because this is a strand and it's different than the screw. But in my experience, when I do CT scan after 6 months, I have 90% of healing bone. Not sure that is necessary to put a lot of pressure between the bone to obtain a good healing. I'm not sure.
We are all orthopedic surgeons. Come on.
Yes.
Some micromotion helps to bone healing as well. So the micromotion helps to bone healing. Yeah.
Thank you very much. It is so that we need a good anatomy, as you said, that everybody who is going to perform a Latarjet, he needs to go at first to the anatomy. Thank you very much.